All right, David.
Perfect. So the chief complaint is asthenia. This is a 18-year-old female that was referred from her family physician to the ER due to transient loss of consciousness. 18-year-old. What she told us is that she went to Nigeria 1 month ago, and when she was in Nigeria 3 weeks in there, she started to have fevers, nausea, diarrhea, and she went to the hospital there, and they told her that he had malaria, and empirically treated her with artemether lumefantrine for 3 days and ciprofloxacin for 5 days. They didn't do any test on her, any rapid test or any other thing, or any analytics. So they treated her empirically, and she improved. The fever resolved, and the malaise also improved, and she came back to Spain. And she was feeling better, but she had a bit of asthenia from this episode. And when she was seeing her family physician, she felt consciousness. She lost her consciousness for a few seconds while waiting, and that's why she came to the ER. She denied any dyspnea or chest pain, and no any other symptoms really in the last week. She was improving. So I'll leave it there and see what you think.
Wow, what a rich aliquot to begin with. And just to make sure, David, I get it right, she's 18 years old, not 80 years old, right? 18. Okay, wonderful. All right, so we have an 80-year-old, like a young woman, who is coming in for an episode of transient loss of consciousness. What appears to be after a recent travel to Nigeria, where she was diagnosed with malaria. So I think it's so easy when you have an exposure and a travel history that is rich to just anchor in the malaria diagnosis, and we love that. But I think before we do that, and before thinking about how that might be related, just thinking about the transient loss of consciousness. And sounds like, from at least the history we have so far, she didn't have any prodromal symptoms. David, do you know if she was like in a seated position, standing up? Do you know the circumstances of around her transient loss of consciousness?
Yeah, she was waiting, standing up, and she started to feel dizzy and had blurry vision, and then lost her consciousness for a few seconds and recovered in the room.
Wonderful. That is super helpful. Thank you so much, David. So it sounds like, she had the prodromal of lightheadedness and blurry vision. So, thinking about like the transient loss of consciousness, oftentimes we think about syncope and pre-syncope buckets. I always, like, in a young person, definitely don't want to miss syncope. We have hypoglycemia, all those good things that we often think about. But in terms of like the syncope itself, the buckets that my first pass is always like thinking about reflex-mediated cardiac causes and orthostasis. With the prodromal symptoms, it makes me more worried about either like orthostasis or in a reflex mediated, especially in a young woman. However, you definitely cardiac etiologies you don't want to miss, especially if she has any congenital issues. And also, like, in a setting of like prior infections and stuff, thinking about like if that could have also lowered seizure threshold. But again, this doesn't quite sounds like seizure to me. So if we like take a step back and something we have to do is like kind of investigate those two buckets would be kind of my first pass of orthostasis, so getting orthostatic vital sign and getting a bit more history of whether she's had this prior episodes in the past, because oftentimes with reflex mediated, people tend to have triggers. And then thinking about like, okay, how is this past history of her travels could potentially be related? And in terms of like the malaria diagnosis, to be honest with you, one thing I have to do, and I don't know the answer to that, is just I think about like, okay, in Nigeria, which of the malaria species are the ones that are most commonly found. So that's something that I would honestly, like in the US, would go to the CDC website and look up. So thinking about it is like falciparum, vivax, which of these, and some of these have complications of their own. So in someone like who has like a prior diagnosis of malaria and who seems to be empirically treated, are we dealing with inadequate treatment? Some of these have like dormant phases. I think Vivax in the liver has a dormant phase that can actually re-enter, or are we dealing with like complications of the drugs themselves, or complications of the drugs itself, complication of the disease itself as well. And I think like once we get a bit more lab and history would be helpful. The other thing, would be informative as always is like, who is this person? Does she have any underlying immunodeficiency, any other chronic issues? Even if she's just 18 years old, that would put her at risk for a transient loss of consciousness. So while like the background with the malaria diagnosis is rich, I would just treat her as any transient loss of consciousness, do a thorough syncope workup, and see what comes of it. All right, David, let's have more information.
Sharmizi, I'm here.
Hello,
Oh, yeah,
Progress.
I'm here with my team.
Oh
They're a
my
little
gosh.
camera shy.
Yes, more brains. So thank you so much for joining us.
Sharmizi, where's the whiteboard?
Oh, the whiteboard is up.
Oh, it is up. Okay, I have to do something with my screen.
Okay. Progress, I can give you a quick summary of the case if that's helpful. So we have David is presenting, so get ready. This is an 18, so we have a case of an 18-year-old woman who has a past history of like about a travel to Nigeria about a month ago where she was diagnosed with malaria and treated. Now, since coming back, she's having more asthenia and had an episode of loss of consciousness, transient loss of consciousness, where she was standing up, felt dizzy, had blurry vision, and she's coming in now in the ED for evaluation. All right, David, the mic is yours.
Okay, so I'll give you a bit more information. Past medical history, none. She didn't take any meds, neither. Family history, none. Social history, she didn't smoke or drink any alcohol or any other drugs. She traveled to Nigeria 1 month ago, as I said. This was her first travel to Nigeria. She was born there, but she came to Spain when she was 3 months old. So yeah, first time there, and she didn't make any prophylaxis for malaria or any other disease. She went there with her family, so they did like usual VFR activities. In the ER, I'll give you the exam. The temperature was 37.5. Blood pressure was 110/70. Heart rate was 105. Respiratory rate was 16. SpO2 99 on room air. Yeah, she looked pretty fine. She didn't look ELRL in the ER. She was alert and oriented ×3. Yeah, HEND was normal. Cardiovascular exam, pulmonary exam, abdominal exam were all normal. Neuro exam, yeah, nothing remarkable in there, and not any rashes, nor yeah, and no edema or any other finding really. Yeah, I can stop there, or I can give you the first set of labs as you want.
David, if you can give us the basic labs, that would be great.
Yeah, perfect. So the first set of labs, the CBC was the white blood cell count was 7.5K. Hemoglobin was 7.3 with an MCV of 88. Platelets were 289K. The basic CMP, sodium was 138, potassium 4.5, urea 27, creatinine 0.8, glucose 96, calcium and magnesium were normal, albumin 3.8, bilirubin 3 milligrams per deciliter, GPT was 61, alphos 120, GGT 168, PCR 9.5. The coax INR was 1.2, TTPA 32 seconds, fibrinogen was 600. And the UA, there was protein around 100 milligrams per deciliter, no bilirubin, hemoglobin was positive, 6 to 10 red blood cells per 5 power field, 100 white blood cells per 5 power field, and urine protein ratio was urine protein creatinine ratio was 1.9 milligrams per milligrams. Yeah, I'll stop there.
David, thank you so much. Jazz, you're too funny, man. But David, what was the prior hemoglobin? Do you have the prior one?
Yeah, so we don't have any
No problem.
prior because she didn't have any labs before this
Got it. No
episode.
problem. So Sharmizi, maybe I can just talk about the anemia and vital signs, and then leave the rest for you to tackle and layer upon. And I have a group right here, so they're going to be able to correct me when I misspeak. So you know, what's so interesting is we talk about this concept of tempo and clinical reasoning, right? If I tell you someone has chronic heart failure, you're going to have time to treat that patient because they have a history of heart failure. But if I tell you a young person presents with no history of heart failure, with sudden onset heart failure, my antenna is up that this patient may need some invasive forms of treatment. It's almost like cirrhosis versus acute liver failure. There's a huge difference. Anemia is the same thing. Acute anemia is different than chronic anemia. In fact, if you can convince yourself you're dealing with acute anemia, it's really one of 3 possibilities, and usually only one of 2 possibilities. And those 2 possibilities are bleeding and hemolysis. The third one, which can happen, is leukemia. They can have acute anemia. So what's really important here is for us to determine, is this acute or not? And usually the best way to determine if it's acute or not is to look at the prior lab. Think about it. When you have an elevated creatinine, you look at the prior creatinine, and if it was normal a month ago, you say, okay, this is acute kidney injury. Now, we don't have a prior lab to rely on. So what other parameters can we use to determine if this is acute or not? There might be some other laboratory clues, but I'll leave that for Sharmini to discuss. You can start with the vital signs. So in someone who has chronic anemia, usually the cardiovascular system compensates and their heart rate is usually normal unless there's another cause that's driving tachycardia. I actually once took care of a patient at the county hospital in San Francisco who had a hemoglobin of 2.5. He was as pale as a ghost. Really, he was. His heart rate was 63. Hemoglobin 2.5, heart rate 63. He had parvovirus B19 leading to pure red cell aplasia, but he had compensated and it was clear it was subacute. So here, with David telling us the story, we may have a reason for tachycardia because we were getting that finding of orthostatic hypotension, but Robbie and I have been fooled many of times where anemia mimics, hypovolemia causing orthostatic hypotension. So looking at that heart rate, I am going to label this anemia as acute. I have to, because usually acute processes require acute diagnosis and acute treatment, while chronic processes, chronic diagnosis, chronic treatment. The other parameters you can use to determine acute versus chronic is there a reticulocytosis? Because remember, if you have hemolysis or bleeding, what would the marrow do? It's going to churn out reticulocytes. Many of the causes of chronic anemia affect the ability of the marrow to actually make red blood cells. And so usually you have a reticulocytopenia. And I'm just going to give one more point of caution. Sometimes it takes the bone marrow time to wake up, meaning that you might have someone with acute anemia and you check a reticulocyte count, it's not too elevated because it just needs time to wake up. But in someone who's 18 years old, you better believe her marrow is probably intact, functioning, and she is going to have a reticulocytosis. So that's something I would be interested in. And to summarize, anemia, like anything else, is it acute or chronic? Use the vital signs. Here, the heart rate tachycardia is suggesting it's acute, and the reticulocyte count would also be helpful. We'll get a peripheral blood smear. And then finally, when you're dealing with acute anemia, the top two diagnoses is hemolysis and bleeding. And maybe I can pass the mic to Sharmizi to see if any of those might be at play here.
We should just say Prof. Poet Reza. That was great. I love it. Maybe one day I'll speak as elegantly. Yeah, I 100% agree with you. I think like the two diagnoses to entertain here is whether there is bleeding or there is hemolysis going on. And, I think we have a story for possible hemolysis, right? Malaria treatment both can lead to hemolysis. But again, bleeding is like one of those things you don't want to miss. So if you think about where a large amount of blood can go is like through your GI tract, right, out to the world, to your GU tract, out to the world, and then in the body, thighs, thorax, and abdomen are the few places that can hide it. Thankfully, she's hemodynamically stable. But however, as Prof. Rez said, like she's an 18-year-old probably with the robust reserve. So but again, like, putting an ultrasound on the abdomen, putting an ultrasound on the thorax, making sure she hasn't had any like bloody stools. And also she has a little bit of like, I think she had a little bit of RBCs. Again, like she was not grossly, she's not having gross hematuria, which oftentimes lead to anemia, rather than like a microscopic hematuria acutely. So I think, investigating those is always a good thought. And then thinking about hemolysis as well. So when it comes to the world of hemolysis, with the diagnosis of malaria, we often think about intracellular causes of that malaria itself can do it. The one thing that I personally have to do is like look up the other two drugs instead of Cipro, other than Cipro that she's been on, to see like what those drugs are, what are the side effect profile, because those are the two drugs I have never used. In fact, I don't recognize it, so that's something I have to look up. So thinking about like whether that could be a side effect of any of these drugs, or are we dealing with the recurrence of malaria, or are we dealing with another disease all by itself? So I think with hemolysis, we often think about like, the environmental environments like the MAHAs. We think about the membrane, like, intrinsic causes versus extrinsic causes of like autoimmune hemolytic anemia, for example, and internal, where there is like intrinsic things like hemoglobinopathies, or that can do it, or like extrinsic, like malaria being one, babesia being another one that can do it. And sometimes like especially with drugs, people can have like G6PD deficiencies, but it's much harder to catch, because like once that episode is over, you're not going to have that as much signs in your bloods to be able to capture that. So now looking at the rest of her lab, CRP is a little bit off, fibrinogen is a little bit high, maybe she's a little inflamed. Other than that, oftentimes with hemolysis, we look at the potassium. Our potassium is like upper limits, but not that high. ASC is another one that I don't see a number, but that could be elevated. But again, I think when it comes to hemolysis, like your haptoglobin is the most specific sign. LDH is often helpful, but the most important thing here to get is a smear and to take a look. And this is like one point I always like try to reinforce with trainees, especially, is that like get your blood work before you give blood. So this is a person that you should still type and screen and make sure you have blood ready for, but try to get those smears, those initial lab work, especially for hemolysis, before you give blood products. So I'm excited to hear more. Prof. Rez, anything else to add?
Okay, great. So I'll give you some of the info you asked for. Well, the retic count was 200,000, so around 8%. LDH was not available in the first labs due to hemolyzed sample, but yeah, in the next day, the LDH was around 1,500. The CK was also elevated around 1,000. The smear so dianocytes only. The direct CUMS was weakly positive. The chest X-ray and the ECG were normal. Basic serologic workup with HIV, HPV, HCV, syphilis was negative. Blood cultures were all drawn that were negative at 5 days. And initially, pan-malaric antigen test, there is this kind of rapid test, was positive, but the thin and thick smears for malaria were negative on day 1 and repeated on day 2 and 3 and were also negative. So I'll leave you.
Okay, so I'll just quickly comment maybe on the LDH in general and then pass the mic to the wonderful Prof. Rez. So I feel like, whenever we say elevated LDH, especially in this context, you have to think hemolysis. I really love that they actually did a CK. Kudos to you all. So thinking about like rhabdo being another thing that is reversible and can definitely cause elevated LDH. The other thing that I often think about that rises LDH, for sure, like lung pathologies, like some really bad pneumonias, infarctions can do it. Acute liver injuries can often lead to it. And, the biggest thing we often worry about with malignancy, like especially in a younger person thinking about leukemia, and sometimes like aggressive solid cancers. But I think in her, again, I think our focus is on hemolysis, and then if that doesn't pan out, then we have to be very thoughtful of like liquid malignancies. But I'll pass the mic to Prof. Rez to layer on the other lab work, mostly because I want to hear
Sharmizi, your discussion on hemolysis is phenomenal. You really rooted us to solve this problem. And I just was telling our team that now all of a sudden the asthenia and transient loss of consciousness is due to the acute anemia. The acute anemia is due to hemolysis. So now the problem just becomes what's driving the hemolysis. And I loved your framework of, is it something with regard to the red blood cell, or is it with something regard to the environment? And what's interesting here is that when you think of the environmental causes, this is the MAHAs, and you always have to have I don't like the word high index of suspicion. I mean, but you should always think about MAHs, and they'll, for the prototypical MAHA of TTP, HUS, DIC, oftentimes those are associated with the thrombocytopenia and then schistocytes on smear, like a single schistocytes. And David didn't tell us anything about schistocytes, and there is no thrombocytopenia. Then the other bucket to consider in the environment, and like right now I'm just focused on the environment, is your autoimmune hemolytic anemia that comes in warm and cold, and warm being IgG and cold being IgM. And usually those have secondary drivers from leukemias to lupus to infections. The reason I'm bringing that up is because we have this weekly positive Coombs test. But the weekly positives Coombs test, I don't know how much to really, put stock into that finding, because it's just weekly positive. And I'm thinking in my mind of secondary causes of warm or cold, and nothing is really jumping out at me. Then you have the environment, the infections. And those infections include malaria, Clostridium perfringens, Babesia, and the one that Dan Minter loves, what is it, Bartonella bacilliformis or something? Dan Minter's an ID doctor. I don't recall it exactly. And so now we have this pan-malaric antigen test that's positive. And we have a thick and thin smear that's negative. So how do we reconcile the discordance between the positive antigen test and the negative thick and thin smear? Well, I'll tell you, I've never really found myself in this scenario, but what I can imagine, I was telling the team that the thick and thin smear is looking for those intracellular parasites, but it all depends on the pathologist or whoever the lab technician is, their ability to actually detect those organisms. So it's easy to see how someone might miss it, or if you have a low degree of parasitemia, it may not be obvious, when the pathologist looks at it. Now, this positive antigen test, if this was her first presentation, at Hopkins, we only did the rapid antigen test for malaria, and it only detected Plasmodium falciparum. It didn't detect non-falciparum Plasmodium species, because there's Vivax, Ovale, there's like 4 species at play. So I just don't know if you can have a false positive test. To me, or if it remains positive because she was recently treated and it's just the antigens and the parasites are cleared. So we still have to seek an alternative etiology. So Sharmizi, where I am right now is I'm not concerned for a MAHA. The Coombs, I think that maybe I would repeat it just to see, but it's not striking to me as this is like a direct hemolytic anemia, Coombs hemolytic anemia. And the parasite hypothesis, I just don't know. Maybe the antigen will stay positive after treatment, and the thick and thin smear being negative lessens its likelihood that it's severe parasitemia, and that pathologist was good at reviewing it. So now I want to go back and think about the red blood cell. And the red blood cell, you already said, like if you start at the membrane, you think about spherocytosis. And we don't have spherocytes on the peripheral smear, like hereditary spherocytosis, but it's not 100% sensitive. You go into the cell and you think about G6PD, and a lot of these anti-malarial medications, I think, can cause oxidative stress. And the problem with G6PD is, like, even if you send the level in the acute setting, it may be normal because those cells deficient in G6PD are lysing. Oftentimes you get bite cells. I don't think David told us of anything about bite cells for G6PD, and we don't have any sickle cells for like a hemoglobinopathy. Before I pass the mic back to Sharmin, because I think I need help analyzing this. David, you said something on the smear. What was actually positive? Was it dacrocytes or?
Yeah, no, I thought the name was same in English, but yeah, what kind of target cells were in Spanish is dianocytes, similar, but no dacrocytes and no spherocytes, neither schistocytes.
So yeah, Sharmizi, I mean, maybe one thread to follow is this Coombs test. And I think the medications, like you meant, I can't even pronounce those medications, but are those leading to some kind of immune mediated destruction? But I would love to hear from you, like, how are you reflecting my thoughts?
Yeah, I 100% agree with you. And I think thinking about the malaria diagnosis, just to make sure, like, oh, was that the correct diagnosis to begin with, or could have been something else that was misdiagnosed as malaria? That could be one possible thread. The second thing about, yeah, I don't know enough about malaria, to be honest with you, to know about like the positivity of the antigen test. And I love the point about you made about thick and clear smears, because like I have taken care of one patient with malaria in my entire career inpatient, and a lot of the times I think you have to think about the operator's comfort and also expertise. And like a lot of the times our pathologists don't see this, so they could potentially miss it. So thank you so much for bringing that up. And the other thing is, if I remember correctly, like um, some of the other species of malaria can have like dormant liver phases. So I wonder, like, if that could potentially explain the positive antigen, but they can smear, are they just hiding somewhere? And should we investigate the liver more? Liver is not giving us that much signal right now. Like maybe the alk that is a little bit elevated, but that's potentially one question that I would probably ask our infectious disease doctors, as you mentioned. And the other thing is, as you mentioned, like I think medications, whether she's having a side effect of the medications, would be like kind of like my top two. Because again, like 18-year-old needs. Most likely this is related to the malaria, or malaria diagnosis maybe unearthed something. But yeah, it doesn't quite sound like an autoimmune hemolytic anemia. So I agree with you. I don't think, yeah, I think like, again, like if you're unsure, doing further workup with the Coombs makes sense. But I think and the other thing is, I think this is part of their reasoning, is that thinking about like what your own gaps in knowledge are. And for me, malaria, so I would probably be a lot more thoughtful and thorough, because there's a lot of gaps that I don't know. So that means like asking more questions related to that, looking things up, asking your experts, just to make sure you're not missing an atypical presentation of like complications or something, just because I'm not as familiar with it. So I would just get more help. Professor, I don't have much to add.
You said about getting more help. I have them like furiously typing up stuff in Google right now to help me out, to help us out.
Yeah, I'm so grateful we live in an age of Chat GPT and Google and up to date,
Okay, so the patient was admitted, and yeah, in the first week of hospitalization, she really felt pretty fine, but she developed fevers up to 38, 39 degree almost daily, yeah, for the first 5 weeks. She didn't have any other symptoms apart from the fever, and that she persisted having some black urines, like, yeah, brown dark urines, yeah. The hemoglobin in the repeated labs were keep falling up to 6 grams per deciliter, more or less. And she didn't develop any anemia or chest pain in that regard. The thin and thick smears for malaria were, as I said, repeated, and they didn't see any parasites. And we also sent a PCR for malaria that was positive for Plasmodium falciparum. And yeah, we were kind of asking this how to match this coordination between the PCR and the antigen test and the smears. And we talked with microbiology that told us that this seemed compatible with treated malaria. in a patient that was recently treated like one week ago. The other labs that I'll give you is the iron panel was normal, like no iron deficiency. B12 and folic acid were also normal. ANA was positive, and it was positive for many different specificities like anti-SSA, anti-RNP, and Coombs test was repeated also, and it was weekly positive. And the parameters of hemolysis keep like very similar in the first week. We also did a screening for glucosase phosphatase deficiency that was also positive. So I'll leave you there and see what you think.
Oh, David, the G6PD, when you say positive, does that mean they were deficient in G6PD?
Yeah.
Okay.
So
Finally, you give us something to talk about with regard to the hemolysis, David.
So I'll specify that this G6PD test is a screening test that you send to see if there's a deficiency. But after that, you have to send a test that will tell you more or less the degree of deficiency that could be. And this was pending. So yeah, don't give you more
Oh, you said this
information.
was what, David?
Pending, that we don't have
Pending.
the
Okay.
yeah.
And one last question for you. The ANA positivity, do you know what the titer was? Oh, you're muted, David.
Yeah, sorry. It was like 1/360, I think.
Okay.
Yeah.
Okay. Well, Sharmizi, we got some stuff to discuss. And maybe we can just like have a conversation like two friends that we are, two colleagues that we are. And I'll just say a little bit and pass the mic. You know, when I first heard the ANA is positive in a young woman, immediately my thought went to lupus. And like we know that lupus can 100% cause a hemolytic anemia, Coombs mediated hemolytic anemia. And I was like scanning what other findings might she have that's consistent with lupus. And we looked at her UA, there's a little bit of protein. It would just prompt me to figure out what the spot protein to creatinine ratio is. I would do like a thorough skin exam. I would look at her hair, and I would go through all the SLIC criteria for lupus. And sometimes it presents with a GN, or it might present with a hemolytic process. But this ANA, like it is elevated, but a lot of stuff is just being positive in her, and it's not like 1 to 1200. And if it was floridly positive, and then you had the Smith, the antibody that was also positive, and low complements, then maybe we're making a stronger case. I don't want to dismiss lupus. You can never dismiss it. So it's in the back of my mind. But maybe before we progress, like what are your thoughts on lupus itself?
Yeah, as someone who always misses lupus, I totally agree with you in most VMRs. Yeah, I think, 100%. I don't think you can dismiss it. And oftentimes I feel like, with us, some of these autoimmune diseases, a trigger that invokes them can be an infection of some sort. So I think it's definitely plausible. And often I think about like, okay, so let's say we're worried about lupus. What is the road to get there and to get treatment would be to make sure she's not having an active infection, and then malaria would be, and that is like she's been completely treated for that before like thinking more immunosuppression. So I totally agree with you about like not letting go of lupus. And I think with that, sometimes like time will tell, like as you as you stabilizes hemoglobin, repeat that ANA, repeat some of these tests to see like if it was a function of like just her immune system being all inflamed, or is this a true infection, a true positive
Thank you for
infection.
that. Yeah, thank you for that. And I think like with this G6PD level, I would have to just put into Google, and maybe someone in the chat can do this. Like, are these medications this patient got oxidative stressors? Because if they are, and you might even get a family history, but G6PD deficiency in the context of an oxidative stress would be a very good answer in this case. And one thing I'll mention is that although the smear could have bite cells because those deficient cells are being chewed up by the spleen, you may not see the bite cells. So you could always review the peripheral blood smear again. But I think the two hypotheses, Sharmin, one is this like lupus that's yet to be diagnosed? We can't dismiss it completely, though we don't have complete strong evidence. And if we want to use temporal association, there's two things: infection that may have triggered autoimmunity, or medication that may have triggered a G6PD mediated hemolysis. That's sort of where I am. I don't know, yeah, where you are, my friend.
Yeah, I totally agree. I think like the repeat UA is also interesting, like brown dark urine. So I would like just repeat like the urine. So I would just repeat a UA to see like, you know, do we see the gap that is just like as all hemoglobinuria, or is this actually RBCs? And as you mentioned, you know, her creatinine thankfully is fine. Yeah, I think the question is like, does she have underlying lupus? And then we gave her some medications, or this is like lupus and like a warm autoimmune hemolytic anemia type pictures. I am still a bit worried about this malaria and like the dormant phase of that. So, but it sounds like, you know, I think like 1 week is like way too short of developing that most likely. Or is this like oxidative stress from G6PD deficiency? And even if it's a G6PD route, I would still, as you mentioned, like keep an eye out for her and lupus in the future, because it's a very like a busy, messy picture, right? So sometimes you just need time to figure out what is that actually true underlying diagnosis. Um, but yeah, any other thoughts, Prof. Red? And the other thing that I was gonna mention, like not that many things give you like cyclical fevers, right? That's the other thing, like that she's having like a fever up to 38. It sounds like cyclical, right? Like once a day, David, was that the case? So that I feel like is also like very malaria-like, right? Like what having like this kind of cyclical fevers. I don't know if I associate that with lupus. But I haven't thought about cyclical fevers in a while. So that's another thing that like kind of makes me nervous about like what is going on with this malaria. Yeah. Okay. Anything else, Prof. Raz? Okay, great. David, teach us.
Okay, great. So I'll give you a bit of the course, but before that, what do you think? What will you do, or would you ask for any other test or any other data before? Yeah.
I would personally just read a lot about like the 3 medications and see if there's any associated with G6PD. Are they like oxidative stressors? Because then that would, with like kind of the screening that is positive, that could potentially explain explain some of the like more hemolysis that she's having. The other question that I would ask, given the cyclical fever, would be like a liver, do we diagnose that with a liver biopsy? That's what I would ask our infectious disease colleague, whether that is a route we need to take. I would repeat a UA. And that's I think what I would do for, and like maybe like for their testing for Coombs to see if this is actually warm autoimmune hemolytic anemia. Anything else that you would do, Prof. Raz?
Zero. That's perfect.
Oh yeah, thank you. Hans mentioned antihistone, which you already had mentioned, Prof. Raz. Yes.
Yeah. and the history and the UAs were negative. So the patient, was pretty fine, and had like 1 week of fever and these dark urines that, as I said, and after that she started this with beginning without fever, and the urines started to clear, to become more clear, and we thought that this was initially we thought that this could be a reaction to the artemether-lumefantrine that the patient had, because these dihydroartemisinin derivatives can induce delayed hemolytic anemia. But this picture of high intravascular hemolytic anemia, reading about more of malaria, seemed to keep very fine with the hypothesis of black water fever. Black water fever is a complication of malaria, of severe malaria, that presents with intravascular hemolysis, with hemoglobinuria, and can develop renal dysfunction that this patient didn't develop. But we were not sure because the patient also received ciprofloxacin that can be a stressor, an inducer of G6PD deficiency. So this was also a possibility. And what we weren't sure about is that why is this patient having such a degree of intravascular hemolysis without any parasite in the smear, in repeated smear? So the presumed diagnosis was black water fever plus maybe G6PD deficiency. But the case resolved, I think, a week later when she went back to home, and she came a bit later, a week later, to the ER again with fever, and thick and thin smear for malaria were positive, and they see parasites there. So we thought that this was like a not well or partially treated malaria. We treated her again with other anti-malarial drugs, and the picture resolved very quickly. So I think this was a kind of black water fever. Don't know if the G6PD deficiency has anything to do with it, because also in females is rare, but this is the case.
My reflection is you guys should go back 10 minutes in this recording. And what did Sharmizi keep saying? She kept saying malaria, despite the microbiologist saying, I don't think, she hung on to that cyclic fever and said, I'm worried about malaria. So Sharmizi, Mike, to you, great job, my friend.
I couldn't do it without you, David. What an amazing case for reasoning, right? Like, and I love VMR for so many reasons, but also you taught me what was it black water fever? I've never heard of that term before. So thank you so much for teaching me. It's like, wow, what a case. I'm just floored. I learned so much. Thank you so much for presenting. Prof. Rez, you're so incredible. When it comes, like, you're just incredible. I just can listen to you teach medicine all day long. But it's so tough. I feel like anything intracellular is just so tough to find and to diagnose. And And sometimes like time will tell. And thankfully, she's a healthy 18-year-old with good reserve who came back. And kudos to you all for going down every rabbit hole to be able to diagnose this. And yeah, these diagnoses are so tough. Learned a ton. Thank you, friend. Uh, all right. And Preet, back to you.
Thank you for the great case and the great discussion. We diagnosed it a lot earlier. And so we'll go with the teaching points. The patient came with the complaint of transient loss of consciousness. When we think about evaluating that, we think to rule out syncope, or sugar, or stroke, or seizure. Basically, we have to rule out these 4 S. And if we talk about syncope, we have reflex syncope, orthostatic syncope, and cardiac syncope. Then we talk about taking the fingerstick blood glucose to rule out if the patient is having hypoglycemia. And it's important to ask about any prodromal symptoms in the patient to consider the vasovagal syncope, or any postictal confusion, tongue bite, to think about seizures. So this patient had a prior history of malaria infection, which made us think about 3 things. If the malaria was untreated, maybe it had a dormant stage. Number 2, it made us think about complications of the treatment of malaria. And number 3, it made us think about complications of malaria itself. So then we think about subjective. We think about if the young lady is immunocompromised. So we think if we need to check her immune deficiency status or any past medical history which can explain the current symptoms. Then we talked broadly about acute versus chronic. Acute versus chronic with respect to heart failure or acute liver failure versus cirrhosis. We think that in chronic stages, the body compensates and we don't need aggressive treatment. But in acute stages, we need aggressive treatment. So similar is the case with anemia. In acute anemia versus chronic anemia, we can differentiate that based on vitals as well. Because the chronic anemia patient, the cardiovascular system, they compensate to accommodate that low hemoglobin. But in acute stages, the heart rate rises. So how do we differentiate acute versus chronic anemia? We do with the prior labs. And if we don't have them, we can see the vitals. And in fact, normal MCV with low hemoglobin also can explain that the body did not have enough time for the compensatory changes. Then we think if we classify it as acute anemia, what could be the main causes? There are 3. 1 could be bleeding, number 2 could be hemolysis, and number 3 could be leukemia. So if we want to evaluate hemolysis, we need LDH, haptoglobin, and smear. And we also discussed that we need to get the blood sample before transfusing any blood products. And then we talked about something about chronic anemia, that which mostly has reticulocytopenia. Also, we discussed that if we want to evaluate anemia in a young woman, we need to check the gastrointestinal tract and the genitourinary tract to evaluate if the cause lies there. Then ultimately, we found that the patient has elevated LDH, which as we discussed about hemolysis, it occurs in hemolysis, but it can occur in other cases as well. It can occur in rhabdomyolysis, acute liver or lung pathology, or any malignancy. Ultimately, then we discussed about the differentials of hemolysis. We can have MAHA, but then in MAHA, we also have thrombocytopenia, which was not the case in this patient. We also have cystocytes. Then the second one was autoimmune hemolytic anemia, in which we test for the Coombs test, which was weakly positive, but we were not able to appreciate any secondary cause in that patient. Then the third cause is infections, the malaria, babesia, and the all other infections. Malaria was present in this patient, but then we discussed that the sensitivity and specificity of thin and thick smear to detect the parasite, it depends on the pathologist's ability to see the intracellular organism. And if they are saying that the patient was infected with falciparum, then this species basically has the highest level of parasitemia. And then the fourth cause we discussed was RBC environment. Is it the problem with the RBC membrane, or is it with the D6PD enzyme? We also discussed that antimalarial treatment can cause oxidative stress, precipitating D6PD deficiency and the hemolysis. Then we found the young woman had positive ANA, which made us think about any autoimmune causes, and we thought about lupus. Lupus can be a secondary cause to form the basis of autoimmune hemolysis, But to confirm, then we look for other symptoms if present in case of lupus, any glomerulonephritis, any evidence in urinalysis, but not finding any positive finding. We then discussed about G6PD. Drugs like primaquine and chloroquine can trigger hemolysis, and even an infection can trigger hemolysis in G6PD deficient patients. But G6PD is an X-linked recessive disorder, so it's difficult to see that in a woman. So then we come over to the final diagnosis when we think what could be causing it. So basically, we were discussing about three things. Is it untreated malaria? Untreated malaria and dormant stages are found in P. vivax and P. ovale. So the patient was infected with Plasmodium falciparum. And number two, we thought about if it's the complication of the treatment. But that looked possible because of the G6PD deficiency. And number three, complications of malaria itself. So it was found to be complications of malaria, that is black water fever, which is a rare serious complication of malaria. And it is found almost exclusively with Plasmodium falciparum malaria. So that's what ultimately we found the diagnosis to be. And thank you so much for the amazing case and discussion.
Wow, that was a masterclass in teaching points, friend. That was amazing. Brilliant job. Prof. Rez, thank you so much for co-discussing. You're amazing. Martha, thank you so much for scribing. David, always a pleasure. I love your cases. Thank you so much for teaching us so much. All right, all. We'll see you tomorrow. Have a good one. Bye.